Welcome back to the PEM Fellowship EKG curriculum. Our topic today is EKG pearls in congenital heart disease. This module should run for about 9 minutes. Remember that you can always refer back to the basics module if you have questions, and that you should pause this module if you need more time to review the EKGs shown. First, let's start with a case. You are seeing a 5-week-old male who was sent from his PCP for persistent tachypnea. The PCP also noticed a murmur on exam. The family notes that he doesn't feed very well, and they worry that he's losing too much weight. His vital signs show a heart rate of 195, a blood pressure of 76/48, and an oxygen saturation of 94% on room air. You appreciate a 3 out of 6 systolic ejection murmur best heard at the upper sternal border. You decide to get an EKG. And this is what you see. Let's use the method we learned in our basics module to go through this EKG together. Calculate the rate, rhythm, and axis. Type your answers in the box and hit the submit button. You should have found that the rate is a little under 150. You can see a P for every QRS and a QRS for every P, so this is sinus rhythm. The QRS complexes are down in 1 in AVF. This means that the EKG has a northwest axis, which is the classic finding for an AV canal defect. Use this enlarged version of the EKG to calculate the PR and QTC intervals. Type your answers in the box and hit the submit button. You should have found that the PR is about 150 and the QTC is 401 if you use 6.5 small boxes for your QT and 10.5 small boxes for your RR. Now take a minute to look at the morphology. When you are finished, hit the next button. You should have found that along with the northwest axis, this EKG has some evidence for right ventricular hypertrophy, or RVH. The RVH can be seen in leads V1 and V2, where there are strong rightward forces, as well as an upright T wave in V1. These findings in any infant over 1 week of age is concerning for RVH. The northwest axis itself is concerning for an AV canal defect. AV canal defects are often associated with RVH and right bundle branch blocks. This patient should be seen by cardiology for an echo and to evaluate for an AV canal defect. The classic teaching with AV canal defects is a northwest axis on EKG. Remember that some AV canal defects may have a superior axis that is not truly northwest, depending on the exact architecture of the ASD. Therefore, this is not a perfect screen for an AV canal defect, but it is an important pearl to remember. Now that we've learned about AV canal defects, let's go back to our case. You still have a 5-week-old male with persistent tachypnea, poor feeding, and a heart murmur. This time, your physical exam shows a heart rate of 160, a blood pressure of 122/60, and oxygen saturations of 99% on room air. On exam, you find a 2 out of 6 systolic murmur at the right and left sternal borders and weak femoral pulses. You decide to get an EKG. And this is what you see. Go through this EKG on your own and type any abnormalities in the box. When you are done, hit the submit button. You should have found that the abnormalities on this EKG are right ventricular hypertrophy and right axis deviation. The right axis deviation is diagnosed because the QRS complexes are down in 1 and up in AVF. You can also see the strong rightward forces in V1 and V2, as well as an upright T wave in V1, which is consistent with RVH. Given the clinical scenario of an infant with an abnormally high blood pressure likely taken in the upper extremity with weak femoral pulses, symptoms of heart failure, and an EKG showing RVH, you want to think about aortic coarctation. Remember that in infants with aortic coarctation, they will have RVH on their EKG because the right ventricle is dominant in fetal life and shortly after birth. As children age, the left ventricle becomes dominant. Therefore, when aortic coarctation is diagnosed in children over 2 years old, or in adults, they typically have left ventricular hypertrophy on EKG. Remember that not all patients with right or left ventricular hypertrophy have aortic coarctation, but in the correct clinical scenario, this should be on your differential. Okay, let's go back to our case one more time. You still have your 5-week-old male sent from his PCP for persistent tachypnea and poor feeding. This time, there is no heart murmur. Your physical exam shows a heart rate of 140, blood pressure of 82/50, and an oxygen saturation of 98% on room air. There is no murmur on exam. You decide to get an EKG. And this is what you see. Go through this EKG on your own and type any abnormalities in the box. When you are done, hit the submit button. You should have found that while most leads look relatively normal, there are abnormal Q waves in leads 1 and AVL. These abnormal Q waves in leads 1 and AVL are concerning for anomalous left coronary arising from the pulmonary artery, or L-kappa. While the Q wave in lead 1 is subtle, the Q wave in lead AVL is much larger than any normal Q wave. Let's take a minute to review L kappa. In normal hearts, the left coronary artery arises off the aorta. This allows for sufficient flow of oxygenated blood to the myocytes. In L kappa, the left coronary artery arises from the pulmonary artery instead. As the infant gets older, the PA pressures fall and there is decreased blood flow through the left coronary artery. This leads to an anterolateral myocardial infarction pattern on EKG. As you learned in the ischemia and infarct module, this causes EKG changes in leads 1, AVL, V5, and V6. Specifically, you might see Q waves, ST changes, and inverted T waves. Therefore, when you see an infant with evidence of an anterolateral myocardial infarction, or specifically with large and wide Q waves in leads 1 and AVL, you should think about L kappa. This requires evaluation by a cardiologist and eventual surgical correction. Alright, let's try one last case of EKG findings in congenital heart disease. This time you are seeing a 7-year-old male with a diagnosis of Ebstein's anomaly. He presents with complaints of palpitations that lasted for 15 minutes that are now resolved. He denies any shortness of breath, lightheadedness, dizziness, or fever. This time, your physical exam shows a heart rate of 84, blood pressure of 106/64, and an oxygen saturation of 98% on room air. The patient has a soft systolic murmur at the left lower sternal border and a widely split S2. You decide to get an EKG. And this is what you see. One last time, go through this EKG on your own and type any abnormalities in the box. When you are finished, hit the Submit button. You should have found that this EKG has delta waves, which indicate pre-excitation consistent with Wolff-Parkinson-White. Approximately 20% of patients with Ebstein's anomaly will have pre-excitation due to an accessory pathway. WPW is a frequent cause of SVT in these patients. Let's think about the anatomy in Ebstein's anomaly. The tricuspid valve is displaced into the right ventricle cavity and there is functional right ventricular hypoplasia. Because of this, you can also see right atrial enlargement and right bundle branch block on the EKG. The right atrial enlargement is usually seen as peaked P waves in leads 2 and V1. Here you can see how the P waves in the right atrial enlargement compare to normal P waves. The key point here is that in patients with known Ebstein's anomaly, look for pre-excitation because 20% of these patients will have WPW. We have now gone through various EKG pearls of congenital heart disease. Some key points to remember are that AV canal defects often present with a northwest axis on EKG, aortic coarctation presents with RVH in infants and LVH in older children and adults. L kappa presents with an anterolateral infarct pattern, most commonly with large and wide Q waves in leads 1 and AVL. And in patients with Ebstein's anomaly, look for WPW as a cause of palpitations or tachycardia. We hope that you are now more comfortable recognizing some key EKG findings of congenital heart disease. Remember that if you are concerned about any of these findings or conditions, you should consult cardiology for further workup and management. As always, we welcome your feedback and suggestions. Thank you for completing this module.